Okay, good morning, everyone. This is the first ACC of 2020, and it's my pleasure to introduce Dr. Jared Baeten, with whom I've been a colleague for a number of years. I won't disclose how many. He has far too many titles to actually list here without taking up a significant portion of his talk, but needless to say, Dr. Baeten is extremely accomplished and an international leader in the field of pre-exposure prophylaxis, and we're fortunate to have him speak about that topic today.
That is the best. Whoa.
You can mute the speakers on there.
Okay, that is the best kind of introduction. Hi, can you hear me here? Are you awake? Good morning.
Good morning.
Oh, that's so much better. Since it's 8 o'clock on the day after a holiday weekend, did everyone have a good holiday weekend? Did you do good things for the world for service weekend? I had a great weekend. It is great to be here, kind of at 8 a.m., but it's great to be here. So I was going to talk about PrEP, and as I was thinking of what to talk about, I went back. I did my disclosures, and then I went back. My first ACC on PrEP was in 2009. So I've known Shrisha for longer than that, since she didn't want to disclose. 2006. Yes, Shrisha is my supervising attending in the Madison Clinic in 2006. And then I talked last year here at ACC on PrEP, like a year and a half-ish ago, we talked a lot about sort of the research, because I think it had been that entire gap from 2009 until 2018-ish. So we talked about the research and uptake and things. And now today, I scrapped all the slides from a year and a half ago and made new slides to talk about stuff really within the last year. And I tried to do mostly images to try to make you want to ask questions. Yes? Yes. Otherwise, we're all gonna be very bored. Okay. So this is the kind of stuff that has, between 2009 and 2018, the clinical trials demonstrated that TDF FTC as PrEP, the branded Truvada, is effective and safe. That then very soon after, FDA, CDC, WHO, countries, lots of different places, including the US Prevention Service Task Force, issued recommendations, and then prescribing worldwide, including a good amount in Seattle. Right, thousands of people in Seattle, tens of thousands of people in San Francisco, are taking PrEP. So what is there possibly to talk about? Well, we're going to cover like 3 different things today. We'll talk about current status, recent research updates, and then one of the things that I'm spending a lot of time thinking about these days is like, what is success for PrEP? Success for treatment has got some for treatment of HIV, which is often the comparison for PrEP. Success for treatment of HIV has got really clear parameters of what is success, right? If someone has HIV and they don't know they have it, or they haven't been offered treatment and they're not on treatment and virally suppressed, that is lack of success, right? So for PrEP, much different story, right? Because the denominator is larger. The denominator changes over time. HIV status doesn't change over time, but being at risk for HIV fluxes during someone's life. So defining success is much more complex. We are at slide 4, and there have been no questions, so I'm getting increasingly sad as we go. So I'm going to look up in a moment from this slide and see some questions. So let's talk about status. So there are about 400,000 people taking PrEP globally right now. The vast majority here in the United States, but goodly, and then, obviously there are, and then obviously good numbers in other countries, France, the UK, Australia, Brazil, Canada, other first and first world and middle income countries that have a fair amount of PrEP use, obviously with the exception of Brazil, much smaller populations to be working with. And then you can see in Africa where the burden of the epidemic is disproportionate, and where I do a lot of my own work. There are two countries that are, that are in this, whatever this darkest, super dark green color is. South Africa and Kenya have more than 25,000 people taking PrEP. The thing I like to remind people is the reason that we have PrEP in Seattle is because of volunteers in Kenya who participated in the clinical trial that pushed over FDA approval. So when you talk to people about where research gets done, it is research everywhere that gets people good things in Seattle and in other places. And so it's good to see that those countries. I am leaving tomorrow for Kenya to where I do a lot of work because we're having meetings on national scale up of PrEP. Kenya has a much more uniform public health service than the United States, and PrEP is available in more than 1,000 clinics nationwide. Walk right in and get for free. These are US numbers. About 70,000 estimated at the end of 2017 is a greater number than that now of PrEP prescriptions. And this is a analysis that was published in 2018. So since the last time we last talked here, that is not the number of people on PrEP, but it's the ratio of new PrEP prescriptions to number of new diagnoses for HIV, sort of a need for PrEP. So one thing you can see is that here in Washington State, you can you barely see Washington? I can barely see Washington. Washington it's better on my computer. Washington is this pale minty green, which means that which is showing that there are 3 to 6 times more people on PrEP than there are people getting diagnosed with HIV, which is good. Not good enough, but good. And that is probably the natural evolution of what will happen in PrEP. As there is diminishing new HIV infections, you will have to be treating more and more people who will not be getting HIV with time to be able to get the last HIV infections to go away. Does that make sense? So as the number of HIV infections goes down, that ratio goes up. So Seattle is both things. Seattle is working on reducing its number of HIV infections, and it's working considerably on increasing number of people on PrEP, and so its ratio is high. You can see in places in red, which concentrate in the south and southeast part of the United States, that the number of persons on PrEP is low and the number of infections is high, and so that ratio is poor. Yeah. Thank you. You get an extra muffin from the mountain that's out there, yes.
I'll be back in 5 minutes. Is there a goal, a target?
Is there a target for that ratio? Well, no, yes. So yes, infinity, right? Because infinity would be no new infections. Right? So beyond that, we'll get to that when we get to, because I would love to brainstorm together on what is defining success for PrEP, because it's setting some sort of target. So of course, Public Health Seattle County has had targets for PrEP, and I can't remember if they've revised the targets recently, but the idea was to try to get 45% of high risk MSM. Now move to 50.
Yes.
Was it always 50? Did it start at 40? Yeah.
It's at 49.
Right. So now it has to be 50. Now it needs to be 60. Right.
Yeah.
Right. So that is, I think that's a good way of setting a target. So I'm going to preview what I'm going to talk about. So I think that's a good way of setting a target because it's setting against a denominator that you can kind of quantify, and it's setting a fraction. And that fraction is never going to be 100 because there is quite amount of autonomy and choice in PrEP, analogous to how there is for contraception. So if you work globally in sexual reproductive health, you know about these targets for contraception. So a country that's got 50–60% coverage of contraception for women at risk of getting pregnant is doing quite well. So 60% for PrEP is sort of an analogy to that would be doing quite well. I don't know how we're going to be able to push it here. 50 is great. 60 would be great. I think it maxes out somewhere above that, obviously. The ratio is a harder one to deal with because the ratio is fluxing against a denominator that hopefully starts to decrease. Does everybody follow that somewhat mathy conversation? It's really early for that. These are data that come out of the NHBS, so they're very city-oriented. You can see the little stars of where the cities come from. This is about PrEP awareness and use presented at CROI this last year. There's been a substantial increase in awareness of PrEP from 60% to 90% between 2014 and 2017, and then an increase in use in these urban centers from 6% to 35%. So these are CDC estimates of the portion of these are MSM in urban centers, sort of selected urban centers, but they include places, they include Atlanta, New Orleans, Miami, San Juan, as well as Seattle, San Francisco, Chicago, New York, and a number of other places. And so there's no doubt, and when we talked in 2009 and 2008, 2018 was at the point where we were starting to recognize that PrEP went from very low uptake for its first few years to be hitting some amount of inflection point and moving up. And that's clearly demonstrated in the NHBS data that 35% of MSM nationwide, at least in urban places, are taking PrEP. That's a great development. I think equally important, this is from this last year's National Prevention Conference. There's been a 5-fold increase in people who write PrEP prescriptions. And I think that's probably actually as important, figuring out that a diversity of people write prescriptions. So like I am a terrible PrEP prescriber as a person in an academic medical center, infectious disease specialist. My catchment of people is much smaller than a primary care provider or a public health provider.
A question from the web.
Oh, nice. Our web.
Where is your prescription data coming from? How do you know how many PrEP doses are being prescribed?
Yeah, so prescription data. So these are from CDC. These are from CDC. Gilead also, Gilead, who's the maker of the branded PrEP, also occasionally puts out data that sort of mirror this. These come from these big clearinghouses that pull prescription data from, what do they say, 75–90% of commercial pharmacies in the United States, and they sort of dissect out who they think is on PrEP based on they're not receiving another antiretroviral, they don't have a diagnosis code for HIV itself, and that presumes that it's PrEP. So I think this is great. The increase in prescribers, this means PrEP moves to primary care settings, to emergency room settings, to gynecologists, to other people who do not think about HIV in their daily lives, but occasionally are called on to think about PrEP, which is great. Like all those of us who do other things occasionally get called on to think about depression or cholesterol or something else that's either treatment or preventative. I would love for PrEP, I said this years ago, PrEP really fits in my mind like contraception also fits like cholesterol, where cholesterol treatment is preventative. Yes, we don't treat cholesterol itself. It's not really a disease, although it has a diagnosis code, but it's preventative against something else. And the way that cholesterol management has seeped into our primary care lives, so it just becomes a natural conversation, would be nice for HIV prevention similarly to do so. So since the last time we talked a year and a half ago, the USPSTF, Prevention Task Force, finally, put out its recommendations that PrEP has a grade A recommendation for prevention, which I think for those of us who did PrEP for a long time, we were doing PrEP without this recommendation. But I think for people who do for people sitting in primary care settings, and to some degree for reimbursement, and certainly for promotion of things within sort of closed health systems, this kind of recommendation makes people think about it more. So if you work for an organization that tries to do its best on all grade A recommendations, this now pushes up into something that you should be doing. Did anybody hear when this happened? I think it's really good news. It was in JAMA. It's got a nice little review that goes with it. And summarizes the data in a nice way. PrEP fits into ending the, so who has heard of the the ending the epidemic activities in the United States. So this is a bold plan to radically change the trajectory of HIV infection in the US, which, you know, as people know, HIV infection in the United States hit its peak in the early 90s in terms of new infections, but then had been relatively stable for about a decade in terms of new infections across the country, falling slowly in these last few years, but not really with any suggestion of moving towards elimination. The federal government bridging several of the important agencies in the federal government, including CDC, NIH, HRSA, and others, aims to end the HIV epidemic through diagnosis of individuals, so better testing, treatment rapidly and effectively, prevention, including use of pre-exposure prophylaxis, pillar 3, and then some sciencey stuff that's trying to do cluster detection to put public health agencies focused on outbreaks of new HIV infection. Yeah.
Sorry, we might have passed this already. Another online question. Any idea when the USPSTF recommendation will impact out-of-pocket costs for patients for clinical services?
Oh, out-of-pocket costs for PrEP. So I would love everybody in the room to comment on their feelings on out-of-pocket costs. So the out-of-pocket costs for PrEP are complex because it is insurance, you know, like all things in the United States, patient costs for PrEP come in terms of the drug coverage and then everything else. And the drug coverage is a mixture of what your insurance will pay, what you're able to get for some sort of fancy card from the company that helps pay for that, and then if you live here in Washington State and in other places, some drug assistance services, and then the other costs similarly so. I think the greatest opportunity for reducing costs in PrEP is the waiting for TDF FTC to be generic, which should be in the near future. And one thing that we'll talk about TAF in a minute or two, but I think the encouragement to everyone who writes prescriptions to think very carefully about whether TDF or TAF are the right things for somebody before switching everyone to TAF, as we all seem to have done for treatment. So back to ending the epidemic. We'll get to TAF in a minute. So the goal for TAF is 75% reduction in new infections within the next 5 years and a 90% reduction within the next 10 years, which is a lot to hope for, but I am always optimistic. The concentration of the end the epidemic activities is on 48 counties nationwide that account for the vast majority of new infections. And you can see that King County, way up at the top, where we are, is one of those, as well as a whole bunch everywhere else. And then seven rural states in the middle of the country and in the southeast where there are epidemics that are not concentrated in cities. So we here in King County are part of this. And I think among the many counties, among these 48 counties, we have the opportunity to be a leader, I would hope. PrEP fits into this is CDC's branding for PrEP as part of the end the epidemic activities with what has become extremely simple messaging, and I'm very happy to see these kind of things. Dramatically reduces the risk of acquiring HIV through sex. PrEP use up from 6 to 35%, as we said 2 slides ago, among MSM in the US. That's CDC's data from presented this last year. Still too low, especially among Black and Hispanic men, MSM, they say here. And then use PrEP. So that's how CDC's branding. I wanted to show what some of the simplicity on branding is up on CDC's website. Globally, and I love to sprinkle in a little bit of global stuff when I come to ACC, is the global estimate, the global goal is 3 million persons on PrEP by 2020. And you can see that the world is less than a third of the way there. Right now, about 400 to 500,000 people on PrEP currently. And so either things are going to be really dramatic this next year, which is some potential. I've heard a major investment by South Africa this morning that they want to be putting several tens of thousands of people on PrEP this next year, but we've got a long way to go. So some recent research updates. Who's heard of TAF? for PrEP? Feelings on TAF for PrEP? What have you heard?
Didn't get that on Descovy.
Oh my goodness, that was the first. That was the first time you can get fat on Descovy. Good. Not good. Not good. Not good. Not good. Not totally true. What? No, not for people with vaginas. Yep. Yep. So women and trans men, the approval is not for individuals whose principal risk of HIV is through receptive vaginal sex. I think is what the technical language. People ask about it a lot. Yeah. Does it work better? No. Okay. Work better. It's different. So it is. We've got two medicines. Old one, new one. Now, anybody who's like lived through the last 30 years of medicines knows that there are old medicines, new medicines. We do this all the time, right? Right? I prescribe Lex something of whatever versions of antidepressants all the time that started out as something without that variant before. So this is very similar. This is the evolution. Or there are 6 different statins on the market. They started with 1 35 years ago, and now there's a bunch. So this is the same thing. This is an evolution of a slightly better through some parameters that were defined before they started testing it. Slightly better version of something else. Tested in the Discover trial. So the Discover trial was randomized non-inferiority trial of what the company's terminology is FTAF. So again, FTC, emtricitabine in combination with TAF, tenofovir alafenamide, randomized predominantly men who have sex with men from the United States and Europe to either TAF-based PrEP or TDF-based PrEP, and you can see it was over 5,000. It's an enormous study. The trial defined that it would finish itself when half the people had completed, when 100% of people had completed week 48, and sort of by definition, given their pace of enrollment, half the people had completed week 96. So half those people got a year of follow-up, and then additional ones got 2 years of follow-up. They enrolled a population that appeared to be at substantial, would in any other setting appear to be of substantial risk for HIV. So the eligibility was 2 episodes of condomless anal sex in the last 12 weeks or a rectal STI in the past 6 months. And individuals could have been on PrEP to come into the study. Their incidence of the most common adverse event, clinical adverse event that occurred during the study was an STI, by far. Like rates of STIs in the study that are among the highest seen in populations in a clinical research study in a very long time, suggesting that in the absence of PrEP, these individuals would have been at substantial high risk of HIV. These are what the results showed. There were 7 infections among individuals who had been assigned to TAF-based PrEP and 15 among individuals who had assigned to TDF-based PrEP. At both of these are HIV incidences that are extraordinarily low, less than 0.5% per year. So it is I think this might be on the next slide. We'll see if it goes to the next slide. In the absence of PrEP, the HIV incidence in these populations would have been more than 5 times that. So in the absence of PrEP, there would have been a lot of HIV infection. So what this demonstrates is that there were very low HIV infection in both of the arms. Now they did what's called a non-inferiority analysis, where they said, okay, we line these up against each other and we see if they're the same, or if the new thing, TAF, is lesser, with confidence, how lesser it appears to be. And this is the non-inferiority boundary. It was the TAF had a rate ratio of 0.47, so reducing HIV risk compared to TDF by about half. Confidence interval that extended past 1, so it's not better than TDF, but didn't extend in a bad way, so it appeared that there was any confidence that it would be much worse than TDF. This meets, by the scientific standards of non-inferiority, it is non-inferior. So it is, by my standards, essentially the same. Yeah.
online question, you may be getting there, but thoughts, speculations on whether full cohort at 96 weeks or 48 weeks OLE may reach statistical superiority.
Oh, so the question is whether the full 96-week cohort will be statistically better. I suspect not, because we'll show this on the next slide. What's here is breaking down those 7 and 15 infections based on use of TAF and TDF. So remember, everybody in the study received a TDF-looking pill every day and a TAF-looking pill every day, and they took both of them, and they didn't know which one they were taking. So there's no difference in sort of takeability of these two pills. They're modestly about the same size, and people in this study had to take both of them. Almost everyone who got HIV either appeared to have HIV when they started the study. So as we all know, there's a window period from when someone gets HIV to when it's manifest in testing. 5, 1, and 4 appear to have been those, so that they were HIV infected at their very first follow-up visit, and that was a very soon after they enrolled, so it was likely that they had gotten HIV before they started the study, and it was just not detectable when they started the study. And then 5 and 10 in the hatched bars are individuals who weren't using. And then 1 and 1 appear to be individuals who appeared whose best test is that they appeared maybe to be using PrEP, although we never know if they were using PrEP at the time you found out they had HIV. You don't know if they were using PrEP at the moment that they actually got HIV. That makes sense? So almost all the infections in the study appeared to either occur before people entered the study or once people on the study but weren't using PrEP, which is what we know about PrEP anyway, which is what we know about TDF PrEP now from a decade of work, is that a decade of experience, is that people get HIV on PrEP when they're not using it. So I don't think that, so the thing that I think is very interesting is that these numbers happen to fall, these are very small numbers, 22 total infections. Other HIV, the studies that demonstrated PrEP efficacy have dozens and dozens of infections. This is 22. They were aiming for a much larger number. If they would have done this study to its full statistical power with something else, it would have been a much larger number. And what you see here is that that almost all of them have nothing to do with PrEP itself. They're sort of absence of PrEP. So I think they just happen to be statistically lucky at where these for the most part, where these numbers fell. That they just happen to, when you take 22 and you happen to divide it into 2 groups, sometimes it falls into 11 and 11, and sometimes it falls into 15 and 7, right? If you were like rolling a die. So they just happen to fall this direction. I do not think that this is strongly indicative at all about superiority about TAF over TDF as PrEP. I think what's indicative is that both of these drugs are exceptionally excellent as PrEP. Yeah, so TAF makes people, Descovy makes people fat. I think that was your quote, right? So there is not strongly from these data, but particularly from the treatment realm, data that put TAF against TDF as part of combination antiretroviral therapy and in a background of other things. And it is, particularly in the background of integrase inhibitors and other things, it is a mixed bag in my mind right now, what this means for PrEP. For the treatment situation, the interface of TAF and an integrase inhibitor appears to be important for substantial weight gain. That was data from South Africa this last year. I think for TAF, for both lipids and weight gain, I'm trying to figure out if it's going to be substantial enough that it's really meaningful for HIV negative persons, especially HIV negative persons who are going on and off. So I do not counsel strongly about, I certainly do not counsel strongly about TAF as somehow health beneficial in terms of weight or lipids for HIV negative persons. I do not think the data are strong enough there. And I certainly do not think so for the most part for people who are taking PrEP, who are 30 something years old and generally otherwise healthy and take it for a period and then not, and then a period and then not. It's a very different question when I think about treatment.
I would also add that there's like 96-week plus data for Venlidi for tenofovir, just TAF alone, in patients with chronic hepatitis B without HIV.
Yep.
That don't really suggest any metabolic.
That's right.
differences.
Right. Excellent. Oh, the I have no idea what the question was. The question was about lipids and weight gain and TAF. And one of the great comment was there's 96-week data for HBV treatment for TAF that did not show metabolic effects. And I think it's really important to say that TAF versus TDF should not be metabolic effects should not be a driver for your prescribing decisions for TAF versus TDF as PrEP. For treatment, maybe a different situation. You're talking about it for HIV. You're talking about individuals who have differential risk of cardiovascular disease and are going to be taking this medication for a much longer period of time in a sustained way. Resistance was minimal in both. Resistance was minimal in individuals who became infected in the Discover trial and driven by individuals with baseline infections, which is what you anticipate, and sort of reinforcing that those 5 and 10 who are the people who did not have good PrEP use did not have good PrEP use, because you don't get resistance without PrEP use. So the FDA had an advisory panel, which was somewhat contentious this past August, and then it's, issued its formal approval, its own approval in October of this year, excluding individuals practicing receptive vaginal sex, which I find infuriating, personally. I mean, it's infuriating on many levels. Infuriating, the data were not enough for HIV protection for women. It is disappointing because I think the data that the translational data for TAF and TDF both translate into the same molecule intracellularly. They just get there through different mechanisms. And so it is very likely that TAF is protective for individuals who have vaginas. And I will say, very interestingly, there was also 0 data for heterosexual men, but that approval went through just fine. Isn't that the nature of things, of the world? So. Any further commentary? Do you want any further commentary from me?
Very much agree with all your frustration on that. One concern raised by this study is it was mostly young Asian MSCs, no comorbidities, and no renal insufficiency, which is a area in which there's a lot of interest. So, do you have any concern extrapolating this?
Yeah. So okay. So the question is the Discover was mostly among relatively young MSM who were relatively healthy and did not have renal insufficiency, and that is. The renal insufficiency part is sort of tied up in the fact that they could have been randomized to TDF, which has a creatinine clearance lower bar on it on its label. And so they had to have at least modestly good renal function, if not good renal function. They were young because it was really mostly because it's trying to attract a population who is at risk for HIV, because they were doing the study did its best to try to recruit a population who should have otherwise gotten HIV. What does this mean for who you'd extrapolate this to? I think the most, so TDF has a different renal, TAF has a different renal clearance bar than TDF does. I think the most obvious population for TAF, and in fact, individuals for whom I would have prescribed TAF even before FDA approval and have been asked to do so in the past few years, were individuals who come in with a creatinine clearance of, 52 or something like that. So I think that makes very easy sense for that population. Almost anybody else, I don't think it doesn't change my opinion otherwise. So there's a very nice, I should have put in here, there's a very nice commentary in, I think in the Annals of Maternal Medicine this last week, that talks about TDF versus TAF, and I encourage people to read it because it makes the case to be attentive, not to just blanket switch our prescriptions all over to TAF because it's available, because what we're looking for here is not necessarily tremendous. We're not seeing necessarily tremendous benefits, and the costs are quite substantial, especially when TDF goes to generic.
Just to support your point that TAF and TDF both work intracellularly, So I think that is it true that it wasn't approved for use in women because the vaginal concentrations of TAF are thought to be less? And how relevant is that? If the drugs are working inside lymphocytes rather than working at the mucosal border, it really doesn't make any sense that the drug wasn't approved for women.
Yeah, so it's excellent. So TDF and TAF both, you swallow them both, and they both make their way into your cells, which is where they have their work against HIV, because that's where HIV replicates, is inside of cells. TAF does a better job about getting into lymphocytes than preferentially compared to other cells, and so it works even better, and it has less, for individuals with HIV, it has less renal side effects because it's not getting into other kinds of cells at the same time. Yes, I totally agree with you that it probably would work equally well in women or in other individuals who practice vaginal sex, because those lymphocytes are where HIV actually invades the body. There's been, since the time PrEP was approved, there's been too many questions about how well PrEP works in women. I would remind everybody that there's yet to be a clear breakthrough infection in a woman taking PrEP anywhere on the planet. So in spite of all of the biopsy pharmacology things, there is no clear evidence that PrEP works when taken any less well in a woman than in a man. Okay, on-demand PrEP. This is San Francisco AIDS Foundation graphic of how to take on-demand PrEP. Who is prescribed 211 here? Yes? Yeah, good for you. Who is conservative and has not prescribed 211 PrEP? I'm looking at a couple people. Who would not? Okay, there we go. So this is 211 on-demand PrEP. 2 hours before sex, the next day and the day after that. And then you keep going if you have sex on consecutive days, and you keep it going until 2 doses 2 days after. Based on the data from the Ibergay study, and then extended into its subsequent open label research called Prevenir, in the context of very high background rate of HIV and high STI rates, showed an 86% reduction in new HIV infections, and the only 2 infections, like in Discover, like in other PrEP trials before that, were among individuals who were not using PrEP. Recent analyses published this last year showed that equally high protection or complete protection among the subset of individuals who had less frequent sex. So one of the questions with on-demand is, you can take on-demand, but if you're having sex every other day, it becomes daily. So it's not really different than daily PrEP. But if you have sex twice in a month, that would be 8 pills in a month compared to 30 pills in a month. Would it work as well? And the best analyses that they can do suggest that individuals during time periods where they had less frequent sex, it appears to work equally well as for individuals who are taking on demand with a more frequent period. And I think this is, the bottom thing I think is very nice. There are a number of studies now, demonstration projects principally from France, where the 211 was first tested, and then the Netherlands, which is nearby, I guess, that when offered in a clinic, about half the people take daily and about half the people take on demand, and about, I think the number is about 15% of individuals every time they come in switch to one or the other. And through whatever choice they're making, which I think is great. So I offer 211 equally. It is super annoying prescription to try to write, but and I try to explain and get filled in the little, the 60 characters we have in Epic to be able to write a prescription. But I offer it equally. Any feelings on 211? Yeah.
So while it's endorsed by WHO guidelines and European guidelines and all over the country, and I say USA guidelines say it's reasonable, the CDC guidelines still say do not do it.
Yes.
And to your earlier point, CDC guidelines also say do not use TDF3TC, which is generic.
Yeah.
So Does that make any sense to you? What's the deal? Are our guidelines just overly conservative?
Yeah, I think guidelines. So this is all my endorsement. So I think guidelines are always slow and conservative. The European European WHO guidelines say that 211 for MSM. So TDF. So 211 has only been tested for individuals whose principal risk factor for getting HIV is receptive anal sex. So principally for MSM and transgender women, this 211 has been shown to be effective. WHO guidelines say it's equivalent to daily dosing, as do European guidelines. CDC guidelines have been slower. I don't know why. It will never get a FDA recommendation because FDA recommendations derive from companies asking for a label change. That will not happen in this case. TDF3TC, I think, is equally effective as well. And there's a WHO statement. I'm conflicted on that one. I chaired the meeting that said that was okay. But the WHO statement that says that 3TC should be equally effective. There are countries in the world that use TDF3TC as their principal PrEP regimen because that's the thing that they tend to import for treatment. And so they, rather than doing like one stream of import for PrEP and one stream for treatment, they've done this. So Lesotho, for example, uses only TDF3TC. And if I lived in Europe where TDF3TC is generic, I would totally use TDF3TC if I couldn't get TDF-FTC for cheap.
Online question. For those who can't or won't engage with the regular provider, should we worry about a slippery slope towards suboptimal 211 for those trying to stretch out their 60 pills for a 2-year period?
So the question is, so do we worry that if people don't engage that they will stretch out their pills? But yeah, to some degree, yes, because like we worry always that people who have difficulty engaging with providers stretch out their pills. This is the thing that I always fear when somebody comes in for HIV treatment when I haven't seen them for 11 months, that they've somehow stretched 6 months of drug to 11. Although somehow that doesn't happen nearly as often as it used to, because I'm so emphatic about talking about don't try to stretch your pills. It's much worse. I trust people a lot. If we can get good messages out there, and I think like this kind of graphic is so beautiful to say, use this. Like, don't use the left half of this, right? 211 is 2 + 1 + 1. I'm okay if people take the pills if I give them a 90-day supply of daily TDF pills, and we have a discussion about using 211 and that stretches out longer, that would be equally fine as using this every day. So here are the WHO guidelines.
Second online question. How do you write the prescription for 211? Can you share your phrasing, please?
Oh, I'm sure it's different every single time because every time I'm trying to fit it in. I think it's 2 doses. It's 2 doses 2 to 12 hours before, 1 dose the next day, and 1 dose the next day. And then I give them a handout like from San Francisco AIDS Foundation to say, look at this and do it this way. I think so I'm going to push through because now we're getting close to time. So it's important to remember that this is why people take PrEP. People take PrEP not because of p-values or publications in the Lancet or whatever else, but because of self-efficacy, trust communication. And this is globally true. It's the same. I thought this was great. This is NBC News from like a week ago. PrEP's unexpected side effect reduced HIV anxiety. So like in true popular press, nothing could be as middle America as NBC News. This was an ad, which I thought, this was a story, which I thought was great. So like, I love it being described as a side effect. Side effect of PrEP is reduced HIV anxiety, which I think is wonderful. I want to talk for a moment about more options. These are PrEP things that are in the development cycle. There's a lot of things always in the preclinical phase, and then fewer things that move into phase 1 and phase 3. But you can see that they're color coded by the active drug, and then the little symbol inside is whether it's a injection or an implant or a vaginal ring or other things. So there's a number of PrEP options that are coming into the future. And the reason that we need more PrEP options is because we're way behind on trying to actually eliminate HIV infection. There's more people newly infected with HIV each year, 1.7 million, than actually who start antiretroviral treatment each year still. So we're still like growing the epidemic as we're trying to contain it with treatment. This is a dapivirine vaginal ring, something that I've worked on. This is for women, developed principally for women in East and Southern Africa, where HIV is disproportionate for women, that showed reduced HIV incidence in both clinical trials and then most recently in open label studies. These are the open label extension studies, DREAM and HOPE, that reported their results this last year. Those, that dapivirine ring, which is an NNRTI worn for a month at a time in women, is now being tested in women who are pregnant. This study has just initiated. I think it's really important to recognize that testing of new PrEP agents for women who may become or are pregnant is super important. We don't necessarily think about it in the United States very much, but for the geography where this work is done, women who will have 4 or 5 pregnancies during her lifetime and then breastfeeds the children that come from that, that's a huge amount of time period where we are generally telling people we have no data for any sorts of medication. TDF has now got fair amounts of data for safety in pregnancy and lactation. The dapivirine ring is just starting to do this. I will point out that we're going to get to the injectable in a minute, but like injectable cabotegravir, if it's shown to be effective for HIV prevention, will have essentially 0 information on pregnancy at the time it gets approved. So we'll have to really be paying attention that studies like this get done for that agent and other new agents. But the way that this is going to get done is going to start with women at the end of pregnancy, used for a short period of time, then have a safety review, and then if that's positive, then move it backwards into earlier into pregnancy, again, safety review, then earlier into pregnancy, and then all the way back to the end of the first trimester, beginning of second trimester. These are some of the other, I want to call out that on-demand products, there are a number of on-demand products being used, being tested in sort of really preclinical or early phase 1 studies right now, but these would be something that would be potent that someone could use right now, and it would work. There is feeling that these types of products might be quite appealing to some individuals who wouldn't want to be taking something every day or wouldn't have something that was living in their body all the time, and so that they would use this at the moment that it's needed. And there's a lot of work that's trying to talk about these being behaviorally congruent. So for a guy who would douche before sex, to put a drug in that douche so that it would work. So if it was fixing into something that somebody's already doing. This up here in the upper right is an insert, sort of like that could be used either vaginally or rectally, that would dissolve quickly. I don't have a picture. I guess I do have a picture of a douche there. It's probably very hard to see. This is some of the preclinical data. These are, or early phase clinical data. These are concentrations of a tenofovir-based douche. And then on the far right is the same sort of thing, tenofovir-based douche in a non-human primate challenge study, showing that the concentrations achieved by a douche are equally good to what are achieved by pills, if not better, at least in rectal tissue, which is where HIV comes into context. So maybe these will be around someday. Cabotegravir long-acting is currently in phase 3 trials for prevention. It is chemically somewhat related to dolutegravir and is delivered by long-acting intramuscular injection, pretty substantial intramuscular injections, not like it's a fairly large dose. There are 2 trials ongoing, HP10-083 and 084, and they are designed very much like Discover, where people are taking both, they're taking both TDF pills or a placebo pill, and then placebo injection or active injection. So people either receive, everyone receives a pill, everyone receives an injection. One of those is active for everybody. The 083 is done among MSM and transgender women, a lot from the United States and South America, and a few other places. And then 084 is in cisgender women, almost all of, I think all of them actually, in East and Southern Africa. These trials, 083 is a little bit further ahead. They are effectively fully enrolled. 084 is over half enrolled. They should have results 2021-ish, 2022-ish. So that would be looking at approval thereafter. This would be an injection that would be given 8 weeks apart when people got into stable dosing, would require coming into a place where someone can get an injection. This is not the kind of injection that you could give yourself, or one could give oneself. Actually, probably any of you probably could not give this yourself. It's a large gluteal intramuscular injection. So even if you're trained, you probably wouldn't want to do this yourself. Pluses and minuses for every PrEP drug. So the challenge with cabotegravir is it has a very long, what's called tail. So if you get a dose today, there is if you're a woman, you get a dose today, a year out, 40% of you will still have drug floating in your body, even though it's for 8 weeks. And the dose that would be given probably is not sufficient to be protecting it against HIV. So when people are on it, they'll be protected. When they go off, if it works, they will go. When they go off it, there will be a period where it's falling, where it will not be working. And so if one is exposed, it may not work and simultaneously select for integrase resistance. This is being examined in these studies. So pluses and minuses for everything. An injection would be easier for many people, but would also stick around a very long time. People may have heard this last summer about islatravir. So there was a implant. So islatravir is a nucleoside reverse transcriptase translocation inhibitor. So it works like an NRTI, plus it like elbows some stuff out of the way. And so it has 2 effects in blocking HIV replication. It has been formulated into an oral dose, which appears to have a very long half-life, an oral dose that could last potentially a month, 1 dose per month, for example, as a pill. And it has been put into an implant based. It's made by Merck, the same people who make Implant and Explanon. So it's an implant that would be about the same size as that. 16 people have had this implant done, and this got like total New York Times attention when it was presented for the summer on those 16 people. But it appears that a dose of 62 milligrams in an implant could have enough drug in it that it would last that you could have an implant that would last a year at a time. We'll see. 16 people, very far from many years from clinical delivery. Thing to think about for implants is an implant is identifiable potentially to family members, partners, or other things. So a pill is identifiable. People see your pill bottle, but you can hide your pill bottle. An implant, if people see your upper arm, is identifiable potentially. So like what are the stigma and cultural contexts around that? And while women there is experience with contraception for women getting implants, there's no equivalent for men at this time, like with the idea of a man having an implant. Which takes me to the idea of options for PrEP. The idea that we will have multiple things into the future is really important for us to getting our minds around, because we will have to at one point start talking about pluses and minuses. This is a study that's ongoing right now that's that's giving young women, assigning young women either to pivirine ring or to oral TDF-FTC, then for 6 months, then switching them for 6 months, and then for the last 6 months, giving them the choice, sort of as a true like clinical trial of choice. We do this all the time, right, for other things in our lives, particularly for contraception, where you present the pluses and minuses of various things for choice. And how we make those decisions is going to become part of PrEP in the long term. This is some data where women were given placebo variants of a ring, an insert, a gel, or a film. And what the story basically is that different strokes for different folks, that people want different things. So the idea that a pill or a shot or a thing is going to work for everybody doesn't seem to make a lot of sense. It certainly doesn't work for contraception. So how will we get our narrative about there's a pill, we're already getting it, right? There's a pill you can take every day. There's a pill you can take 211. There's a different pill that you can take every day, which hasn't been tested for 211. There's an injection coming maybe into the future. How will we be able to talk about the pluses and minuses of each of them? Because each of them is going to have pluses and minuses. So that's what we might look into the future. So the last piece is on defining success, and I'm almost out of time. But the pieces that I think about a lot are like what flows into the impact we want to have. And it has to do with how much uptake there is, how much adherence there is, how much persistence there is, and then really translating to how much coverage you get. There is not great science to figure this out right now. This is, again, back to end the epidemic. This is how far we are. There's 1 million people by CDC estimates, 1 million plus, who would benefit from PrEP, and we've got 75,000 currently in the United States. These are data from clinical trials and then from Gilead. On the right from Gilead, this is how well people took PrEP in 2012, 13, 14, 15. So like looking at how adherence got better and persistence got better as PrEP became more normalized in the United States. And the data on the right, data on the left side are HIV incidence in population studies, clinical trials, and open label studies showing how much better people got at taking PrEP as time went on. The HIV incidence went effectively to 0. I'm going to skip that. I'm going to skip that. This is data from the United States showing changes in new diagnoses as PrEP rolls out more. I think this is what we need to be looking at when we're defining success, is that as counties in the United States or states in the United States that had more PrEP rollout, the highest level of PrEP rollout saw decreases in HIV infections. And we've seen the same thing in San Francisco. These are new HIV infections in San Francisco from 2006 to 2018, coincident with lots more testing in PrEP. And this is last week from the UK, which they attribute a lot to PrEP. And the UK is at 93, 97, 97 for its 90, 90, 90 rule. So that translates to about 87% of people are virally suppressed who are living with HIV. So it works hand in hand, but you need to get PrEP coverage fairly high to be able to really have substantial reductions in HIV. We're at the top of the hour, so I am going to stop. Thank you. Final questions, or come up here?
Jared, do you think we should be matching the mode of action of the drug with the delivery method? So, for example, things that are delivered mucosally should block attachment, whereas things that are delivered systemically and work intracellularly can be administered a variety of ways.
Yeah, to some extent, yes. I think there's a lot of crosstalk on how we administer things and what kind of drugs we use. If we use something that's mucosally delivered, it has to be rapidly acting, whatever that is. So either has to block attachment or has to be sort of very quickly be able to be phosphorylated or whatever, right, taken into cells and phosphorylated. I think there's a lot, the development agenda for new PrEP products has a tension between things that people will use and things that we can have greater control over. So an injection given systemically or an implant given systemically, from a product developer point of view, you have a lot more control over its use than handing something to somebody to use. I think we are going to get to we have to get to a lot more about figuring out what people want and what people are going to use in the long term. Because there are plenty of people who have access to TDF PrEP right now who don't take it because it's not fitting them in some sort of way. For some of them, something that they don't have to think about, like an injection or an implant, will get there. And for some of them, it won't, because what they want is something that's super easy, if not over the counter, that they could use right now.
So that was a great talk, Jared. I was very curious about that data showing improvement in PrEP adherence as the years have progressed with us just having familiarity. And I was curious if, your analogy to the contraception world, whether we've seen the same thing happen with like societal buy-in, or, that's the first time I'm seeing data like that. Right. And I find that kind of striking.
I love that graphic. So we just wrote this commentary on defining success, and we use both of these graphics. I think it's really striking. So so many of the comparisons to contraception fit with PrEP, right? So that it's under individual control. People go on and off of it. There's a choice of things that people can use. Not everything. So some women really like to take a daily pill because they have great they have great control over what that means. There's someone who would never take a daily pill and love to have an implant. There's some women who would say, I would never have something that lived in my body all the time. And so they would, you go from one to the other to the other. The analogies, I think the analogy for contraception is very relevant. So the use, what there is for contraception is contraceptive persistence. It goes up as you take the barriers down. So the things that have made the biggest revolution in the last 20 years for contraception have been long-acting things and multi-month prescribing. So writing a prescription for oral contraceptives for a year and not making people have to see you, and especially if they can get it mailed to them, super increases contraceptive persistence. And so for PrEP, that should be the goal, that we should be. So my own patients on PrEP sometimes make it every 3 months to see me, but sometimes just make it for an HIV test every 3 months, don't see me, and they have 6 months of PrEP ready for them. And so I try to reduce the barriers as much as possible. Getting pharmacy type delivery of PrEP, like we have here options in Seattle, and they're expanding options across the country for pharmacy only delivery of PrEP, where people can zip and see a pharmacist, get an HIV test done, get their things done, or mail order delivery of PrEP, where you could like send in your own HIV test or photograph your HIV test or whatever else, so that you can have continuous refills on PrEP, will allow persistence to go up. So some of this is familiarity. The things that push that even higher, like they have for contraception, are removing the clinical provider necessity piece of it from the ability of people to be able to use the things they want, that they're going to be using anyway.
Do you know of any adherence tools for 2-on-1 PrEP?
Oh, adherence tools for 2-on-1. I do not. I probably should. I do not know of adherence tools for 2-on-1 PrEP. Right, because the biggest challenge with 2-on-1 is remembering to do it. Because the greatest advantage of daily PrEP is you get into a rhythm of doing it. And if someone gets, habit development, if you get taking it and you're taking it every day, it's harder once you develop that rhythm to fail to do so. 2-on-1, you have to remember to do something before, you have to remember to do something ahead of time and then take it the next day and the day after. So I don't know of reminders for that, but someone should, I don't know, make an app or something. I don't know.
That's what I was envisioning.
Right. Yeah.
It's not, it would be great if it was integrated into apps like Grindr, where
right.
you could be a prompt.
Right. When you click, yeah. Right, yeah, it activates when you, I don't know, swipe left or something instead. Yeah. Okay, we're done. We're done. I've been told we're done. Thank you, everybody. Woo.